Well, hello, everybody. Good afternoon. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. And I'd like to welcome you to today's live webinar hosted by ATTAC Consulting. It is called How Providers and Health Plans Can Collaborate to Maximize Revenue and Quality. And this is a really exciting topic that I think you will find very interesting. I've had a little sneak peek of what's going to be talked about today. So I'm very excited to hear from our speakers. A few items of note before we get started today. This is a traditional webinar format, so everyone has joined today in listen-only mode. So you don't need to worry about turning your camera off or muting your microphone or anything like that. All that's been done for you. So you just have to sit back and enjoy. However, we would like to hear from you. We're going to have a time for some Q&A towards the end for our speakers, so you'll get a chance to ask them questions. So at any time during the presentation, if you have a question, go ahead and drop it into your control module. There's a little place for questions there, and we're going to get to as many of those as we can with the allotted time. If for some reason we don't get to yours, someone will reach out via email afterwards. So go ahead and drop your question in, even if we're wrapping up right at the last minute there. And then finally, the session today is being recorded. So when we're done here, you'll receive an email in an hour or two after we conclude, and it will have a link to the recording as well as where you can access the slides as well from the presentation. Yeah, I think that's about it. Without further ado, I would like to introduce our moderator today. Is John Gottwald, and he's the SVP of Sales and Client Services with ATTAC Consulting, and then he will introduce our other speakers today. So welcome, John.
All right, thanks, Garrett. Appreciate it. Good afternoon, everyone, or good morning, depending on your time zone. And as Garrett said, welcome to our webinar. A little blurb about ATTAC. You can see the lines of business we cover, both payer and provider, and the areas we specialize in. And we actually turned 20 years old this year. We got the gold star for our 20th anniversary, which if you do the math, we've been around since 2003. And we're happy to host today, and we hope you find this very informative. Our speakers for today are going to be Charles Baker, who's our VP of Compliance Solutions, our Division Lead of Provider Network Management, Jocelyn Bayless, and then Alan Bratton, our Risk Adjustment OpEx Guru. And a little bit about Charles. Charles is a former Medicare Compliance Officer and also a Director of Risk Adjustment at a large regional health plan, which served over 1.6 million members. Charles also has Medicare operations experience, as well as experience in physician leadership, and is a former adjunct facility teaching population health and epidemiology. So right on cue for our pandemic we recently had. Jocelyn, she specializes in large scale provider network contracting, very appropriate for what we're about to cover today, including network development and management strategies, as well as provider network operation functions. Jocelyn also has experience in provider compensation models for Medicaid and Medicare, as well as commercial programs, including topics such as risk sharing and quality incentive designs. And lastly, she held senior roles at Wellcar Health Plans, Florida True Health, and then served as a COO of an ACO located in mid-Florida. Location is secret. We can't tell you. We'd have to kill you. Lastly, Alan Bratton, he's a former COO of a Medicare Advantage organization with over 25 years of experience in project management and experience in government healthcare programs. Along with his Medicare Advantage experience, Alan previously served as an SVP and CIO for government healthcare solutions with Xerox, little company you might have heard of, and he supported the division managing state Medicaid MMIS systems. So a little bit about our speakers and lots of years of experience, so I'm looking forward to what they have to say. Quickly go over the agenda. You can see it's about collaboration and partnership, and we're going to focus today on the latest trends in STARS and HEDIS, as well as risk adjustment. Talk about a little bit of the exposure for both health plans and providers. And then, as we mentioned, as you can tell by the title, we're going to focus a lot on collaboration and partnerships between health plans, ACOs, and provider organizations. All right, now that we got you warmed up, we're going to see how your engagement level is. We're going to jump right into a polling question. And your screen is about to change. How familiar are you with quality and risk-related requirements for MCOs and ACOs? Please select one of the below. All right, your screen should have changed so you can vote. Okay, looks like about 2/3 have voted. We'll leave it open for a few more seconds here. Okay, I'm going to close the poll in about 3, 2, 1. Okay, so very interesting results. Looks like most of you are kind of right in the middle. So right in the middle for right in the middle. And these results will be shared with you once Garrett follows up with the recording as well as the deck. Okay, now I'm going to turn it over to Charles Baker. Charles?
Hey, thanks for that warm introduction, John. As John mentioned, I'm Charles Baker, Vice President of Compliance Solutions with ATTAC Consulting. First, I just really kind of want to level set for the presentation and hand it over to some of my content experts and Alan and Jocelyn. So to start out here, I just want to talk about some trends that we're seeing within star ratings and the risk adjustment world. In 2024, the CMS star ratings and risk adjustment modeling are undergoing significant changes, which will have a profound impact on healthcare as we know it. One key shift is an increased emphasis on the quality of care as a means to drive down the total cost of care. Remember, this work is about quality, not quantity. Providers are now being held more accountable for the completeness and accuracy of their documentation, enforcing partnership with the health plan. There also continues to be a heightened focus on health equity and social determinants of health measures, indicating an ongoing commitment to addressing disparities in healthcare. Above all, the central theme is a renewed focus on patient-centered care, with quality being a top priority. Next slide, please. I want to provide you with some real-world data here in regards to some of these changes. CMS are clearly seen through the 2024 star ratings, which showed an average decline in average performance by approximately 0.25 stars compared to the previous year. CMS has notably increased the weight of controlling blood pressure measure from a 1-time to a 3-time measurement weighting, which emphasizes the importance of managing chronic conditions effectively, a crucial aspect of high-quality healthcare. The plan all-cause readmission measure has been reintroduced to the star ratings. Its presence underscores the need for reducing hospital readmissions, a vital indicator of care and patient outcomes. Additionally, CMS has evolved its approach to care transitions. Instead of standalone medication reconciliation post-discharge measures, we now see broader measures like follow-up after emergency department visits for patients with multiple chronic conditions. This shift highlights the importance of continuous care for high-risk populations. For me, I think most importantly, the introduction of the Health Equity Index underscores CMS's commitment to health equity, ensuring high-quality healthcare for all, regardless of those social risk factors. These changes in the CMS star ratings demonstrate a strategic shift towards enhancing healthcare quality with a particular emphasis on chronic condition management, care transitions, and health equity. Next slide, please. Along with our STARS measures and our risk adjustment measures, HEDIS measures continue to play a pivotal role in connecting providers and health plans to enhance healthcare quality and control cost. In recent years, HEDIS has placed a significant emphasis on equity, aiming to close gaps and ensure equitable healthcare delivery for diverse patient populations. Understanding the HHS, HCC, and CMS HCC's models is critical for providers because accurate coding and documentation directly impact their reimbursement and quality of care. Documentation should accurately reflect each patient's medical history and face-to-face encounters with physicians to support quality of care and fair reimbursement. We all love our acronyms in healthcare. Remember, MEET, monitoring, evaluation, assessment, and treatment serves as a practical reminder of the key components needed for accurate documentation and coding in order to ensure quality of care and fair reimbursement. With that, I'm going to hand it over to Alan Breton.
Yeah, thanks, Charles. Before we switch over to Alan, I did want to remind everybody, as Garrett mentioned, provide questions in the question box in your control box of your webinar, and we will answer questions at the end of the presentation. We left plenty of time for Q&A. With that, thanks, Charles. I'll turn it over to Alan Bratton.
Hi, good afternoon, everybody. As you all know, health plans and providers have a mutual dependency particularly in our healthcare system in the United States, and in particular when it comes to risk adjustment and quality initiatives. The health plans, they rely on the provider groups to see the members, understand and address potential gaps in diagnosis or care, properly document diagnosis, services provided, et cetera, and then to follow up with the member to make sure that they're following on their care plans and getting the care that they need. And providers rely on the health plans to get member flow, be supportive of rate structure, maybe protect some terms that are important to the provider group. And then they both rely on each other for the reputation of the healthcare that's delivered by both the provider and the health plan. And this symbiotic relationship, when well executed, it enables both to successfully provide healthcare services, but also when issues arise, there can be an impact on both. Go to the next slide, John. This can be indicated by recently over the last several years, the Office of Inspector General has been publishing audit reports. And these audit reports are particularly focused on Medicare Advantage plans, and it's targeting diagnosis codes that the OIG considers at high risk of being miscoded or upcoded for risk adjustment purposes. And between February 21st, 2021 and November 2023, they've issued 31 health reports on 31 health plans. These reports have covered plan years 2015 through 2018 to date. Actually, there's one that's gone into 2019 now. And the process that they go through is they select a universe of HCC that they expect or they suspect of being inappropriate. And then they'll go into a health plan and say, hey, we believe you've got a problem here, so give us 30 of each of these conditions. So they do a sample. So of the 31 health plans that they've audited, they've come up with 4,227 member years for these 10 conditions that they've sampled. And those sampled member years have indicated an overpayment of $10.4 million, which is money, but that's not the real money. When they extrapolate this over the full universe of suspect conditions over those 31 health plans, it's $581 million. So it's a very expensive situation that the OIG is trying to detect and correct, and they're claiming very large overpayments, and this is just over 31 health plans to date. Given the financial picture, the OIG is continuing these financial audits and will continue them until they're seeing a change in the behavior of the health plans. One thing of note, a typical audit is the OIG or CMS comes in and says, hey, we're going to do an audit. Here's the criteria. Give me a universe and I'm going to select a random sample. In these cases, if the OIG shows up for an audit, there's a high likelihood that they know that there's a problem because they're monitoring data that is submitted to CMS, and then they're already weeding out those health plans that are performing well, and they're focusing in on those health plans that, based on the data they're submitting, have a problem. So they're already showing up with the universe in hand. And if they show up, there's a high likelihood that there's a problem that's going to have to get addressed. Next slide, John. So specifically what the OIG is looking at are these four groups of conditions: acute stroke and or heart attack. And what they're looking for there is a single diagnosis in a physician's office with no follow-up hospitalization. So somebody is documented as suffering a stroke in a doctor's office, but no hospitalization as follow-up. They're considering that as suspect. Major depressive disorder and embolism, single diagnosis codes with no corresponding pharmacy therapy, drug therapy. Vascular claudication, again, a single diagnosis with no prior diagnosis in 2 years and then they're looking at a particular type of drug. And then the cancers, they're looking for a single diagnosis with no treatment in a window plus or minus 6 months. I'll note this actually on the other slides, but major depressive and vascular claudication, they've started to drop from the newer audits. It's mainly because the health plans have done a pretty good job of documenting those, but we'll see that in a second. Next slide. So when you look at the conditions that I just outlined, those 10 conditions in the chart, you see the vascular claudication, the major depressive. Those had a 75 and an 80% success rate. The health plans defending those cases, and so they've been dropped from future. It appears that they've been dropped. The OIG hasn't confirmed this, but the most recent reports for more current years have dropped those 2 conditions. But basically when the OIG does the audit, there's only a 26.5% pass rate. And of those 31 plans, they've identified 165,000 suspect cases across these 10 conditions. So there's a large number of these conditions that they're identifying for a relatively low number of plans. And then dropping down, when you look at the overall conditions, 72% of those audit cases have not been validated. But when you drop out the vascular claudication and major depressive, 91% of those sampled cases have failed to be validated. So literally 1 in 10 are passing. So 9 in 10 are not being successfully supported. Next slide. We needed to put an eye chart in here for everybody, so here it is. The blue lines include all 10 conditions. The orange lines are dropping out the major depressive and vascular claudication. And the point of this slide is this shows the results from each one of the audits. And the successful substantiation rates range from 3.8% to 23.8%. So when the OIG shows up, the best performing plans are only substantiating 1 in 4 sample cases. So again, that's a high indication that if they show up, there's a problem. Next slide. So the reason we kind of walked through this in a webinar that's entitled, collaboration between providers and health plans is the health plans are being audited but this can be a provider problem as well. If a health plan is being chased for tens of millions, 20, 30, $40 million, I think the largest is about $190 million, then they're going to be looking at what is the root cause. And some of these costs could flow down to providers. In particular with value-based agreements that have a flow down provision. So as the OIG and the CMS pursue reimbursement for this money, if there's a flow down provision from the MCO down to the provider, that if they fail an audit and it's indicated as at a cause caused by the provider group, they may start chasing the providers for that, especially attributed providers. So this could have an impact through reclaiming of capitation payments, reclaiming of quality payments, and possibly liquidated damages depending on the contracts. The other thing is these payments are identified for plan years, 8 years in the past. So there's a significant reserve that the payer of these funds has to have in place to be able to pull enough cash out to make those payments. So as a provider group, as a health plan and as a provider group, being aware that these audits are out there, they're prevalent, and the CMS is getting more aggressive in pulling that money back, and also that these are old payments, which is going to require access to cash to cover them from years gone by. That does create a scenario that can be difficult for the health plan and potentially a provider group. Next slide. So again, the reason we bring this up in a collaboration type of webinar is that this is a problem that both parties rely on each other to prevent and mitigate, and both can be proactive in preventing and mitigating these audits and the impact of these audits. A couple of the strategies can be, first of all, these are not difficult conditions to detect. If somebody is getting diagnosed as having a stroke in a doctor's office and there's no hospitalization follow-up, the data can point that case out, and that can be followed up on. So strategy number one is to figure out how do we address these cases, these particular 10 cases that we know the OIG is documented, but also are there other similar outlier cases that would make sense to put on the list. The other thing is to establish tools to measure patient compliance with care plans, and this is partially in place already with several of the HEDIS measures. But for example, in the cancer situations that the OIG is looking at, somebody is diagnosed with cancer but has a active cancer diagnosis with no treatment, plus or minus 6 months from the date of service. There are some cases where that may be perfectly legitimate, but in most cases, there's probably some care that's not being followed up on that the beneficiary would need, again, if that's a true active diagnosis. So following up patient care, compliance with their care plans is also a strategy that would prevent some of these conditions that are legitimate. Reviewing the contracts and audit-related clauses, making sure that the health plan and the providers are both fully understanding what those are. And this is a case where a provider can, their provider group's performance in these risk adjustment documentation can be a benefit in negotiating with health plans. And then health plans can protect themselves by pushing providers towards these types of clauses. Determining the appropriate collaboration, with plans in the event of an audit finding. How is the provider group and the health plan going to collaborate when audit findings occur? How are you going to detect the cases? How are you going to follow up on the cases? And making sure that there's a mutual plan of action that both will undertake together. And then, as I said earlier, proactively collaborate between the health plan and the provider to identify these suspect cases and get them addressed ahead of time, so that the OIG isn't finding them. Then, from a quality care perspective, if somebody is legitimately diagnosed with these conditions and not receiving follow-up care, or not going to the hospital, or not following up with their medication, then that's a problem that should be followed up. So part of this is detecting the problem from an administrative perspective, but the other part is to detect the condition to see if there's a member quality of care issue that needs to be addressed. And so that would be something that would be readily put in place to make sure that members are being properly seeing their proper care.
All right, thanks, Ellen. Appreciate that. All right, now we're going to move on to our second polling question. How confident are you in understanding the impacts of risk adjustment on your organization? Please select one of the answers. Your screen should have changed. Okay, looks like about a third of you have voted. That's good. Okay, we're about half. Leave it open again. How confident are you in understanding the impacts of risk adjustment on your organization? Please select only one answer. Okay. Looks like we are just about finished. So give it a few more seconds. Still getting some stragglers, so I'll leave it open. Okay. 3, 2, 1. Okay. Looks like almost a 50-50 split. So, which is good because that is something that we'll be talking about, and I will turn it back over to Charles.
Yeah, thanks, John. Appreciate that. Can you hear me okay?
Yep, loud and clear.
All right, so now that we've given you the doom and gloom of decreases in star rating performance and OIG and CMS and their enforcement action around risk adjustment and the ever-changing landscape of providing quality-based care within the industry, what can health plans and providers do to strengthen their relationships? How do we move forward with the patient at the center of all of this? I think that collaboration between the provider and health plans is essential for achieving mutual objectives and strengthening the relationship. Part of it is establishing mutual objectives as a first step, clearly defining objectives and creating a roadmap for success, supported by metrics and data, which will enable providers to focus on those key performance indicator and make those administrative adjustments as Alan was alluding to earlier. One thing that we've seen to be really effective is creating a joint governance structure, such as steering committees, to be able to develop operating rules, roles, and the scope of the collaboration. Again, I think that we all work really well together within the confines of rules. Give me the rules, and I think that we can be very effective within them. Effective communication and expectation setting is key to successful collaboration. Clear communication is vital. Setting expectations about what is needed from the health plans for physicians to be successful ensures that alignment. providers can request support from health plans, and the health plans are typically more than welcoming of that request to ensure that data feeds, staff augmentation, and analytics reports really meets their needs to achieve quality for members. Next slide, John. Secondarily, data exchange and collaboration is really important as well. Making sure that that patient is at the center of everything that we do. It's that collaboration is really critical for informed decision making. Sharing clinical and claims data allows both parties to access and mine intelligence and facilitate collaboration of individual patients and populations of patients. This relies on a leadership commitment and reimbursement alignment to ensure that incentives are aligned appropriately to meet those objectives. A comprehensive operating model and integrated data systems are also essential for effective risk adjustment and data-driven decision-making. In this next slide, I want to talk a little bit about some of the statistics on why this collaboration and communication really work effectively. One study published in the Journal of American Medical Association found that collaboration between health insurance and providers can lead to significant cost savings. The study looked at a program that involved a health insurance provider working directly with healthcare providers to improve care for patients with chronic conditions. Over a 2-year period, the program resulted in a 25% reduction in hospital admissions and a 17% reduction in emergency room visits, which led to a cost savings of $30 million. Another study in the Journal of Managed Care and Specialty Pharmacy found that collaboration led to better medication adherence, with a 4% increase in adherence, resulting in a cost savings of $1,260 per patient per year. Optimizing the roles and responsibilities within care management is crucial. This includes understanding and optimizing the roles of care management team members, such as utilization reviewers, care managers, social workers, and administrative staff. This efficiency in care coordination not only improves patient outcomes, but contributes to the overall success of the collaboration between provider organizations and health plans. Next slide, please.
All right, thanks, Charles. Appreciate that. So this leads us to our third and final polling question. What are the top challenges you face to establish/maintain a contractual relationship between a health plan and a provider organization? And unlike the other poll questions, please select all that apply. And your screen should have changed. The poll is now open. And again, please select all that apply. It looks like half have voted, so I'll keep it open. All right, we're in the home stretch of voting. Couple of stragglers here. And again, we will share this deck as well as the polling results with you. Okay, a couple more seconds. 3, 2, 1, and the poll is closed. Very interesting distribution of answers. "32% other," that's very interesting. So, okay, again, these will be shared after the webinar is ended and Garrett will distribute these. All right, we're going to move on to Jocelyn Bayless. Jocelyn, I'll hand it over to you.
Thank you so much, John. Hello, everyone. Thanks for taking time out of your day to join us. So I'm going to kind of tie all this together. You heard a lot of great information from both Charles and from Alan. So when it comes to really positioning yourselves to be a valuable partner, whether it's health plan or provider organization, there's a couple key areas that both sides really need to kind of look at and understand. As we talked about, quality is so key, right? And from a quality perspective, that doesn't just mean looking at HEDIS measures. It's the HEDIS measures, it's the star ratings, it's the risk adjustment. And, you know, that's one way of how health plans are measured, but it's also looking at how are your provider panels, your provider organizations, what's the level of quality that your providers bring to the table? So it's really good for, as a provider organization, to understand how plans are measured by quality, but also to make sure that you're measuring the quality of your provider organization to help show the value that you bring when you're in a negotiation or in discussions. The other piece would be provider data accuracy and maintenance. For those of you that have worked on the health plan side, you know this is a huge pain point across the industry, is being able to have accurate information to make sure members can get the right care at the right time. And you lean, as a health plan, you lean heavily on the providers to maintain that data and send accurate information to the health plan for notifications. But we also understand, I've worked on both sides, I've worked for the provider and for the health plan, and fully appreciate that in the provider side, sometimes you just don't have the resources. And we just want to make sure that there's a strong awareness across the industry on both sides, especially on the providers, how important it is to make sure that as you have changes in your phone numbers, practice locations, those all impact your patients and the members. And there's a lot of scrutiny, I'll say, from regulators to make sure that this data is being maintained because it all impacts care. Another component that health plans are being, evaluated on is network adequacy and coverage. And so as a provider organization, you want to understand, what kind of coverage do you bring to the table? What's your value add to the health plan? You know, from a health plan perspective, you're having the discussion with the provider to understand where they can increase adequacy and increase care, and also help achieve your guidelines and your requirements with your parent entities or regulators. So I just want to share at a network adequacy perspective, this is looking at time and distance. So it's by specialty, by county typically, and what those time and distance standards are. So when I worked in the ACO, for example, I made sure that we were thinking through not only the primary care services and coverage we offer across our county, but it was also looking at what kind of specialty services do we have, and are we really aligning ourselves with that whole continuum of care? Whether we had a direct relationship with those specialists or just a preferred relationship and referral pattern, were all looked at. So when you're in the negotiations with a health plan, if you're on the provider side, I would suggest just understanding your coverage. What service area do you really touch? And there's great resources available, whether it's Medicaid, Medicare, commercial, of, what are some of those requirements. Medicaid goes a little bit beyond time and distance into some of the county designations as well. Access and availability is really important, again, about getting access at the right time. And health plans are obligated to make sure that providers are held to appointment standards. I know working across the years, so many providers get so frustrated with the health plans for surveying them or, trying to hold them to these standards, but it's not the health plan that's dictating this. This is really government regulation to make sure members are getting the right care in a reasonable time frame, and following up on those hospital discharges for medication adherence, things like that. So it's really important to look at your access and availability in your scheduling appointments. Communications and engagement, I think that Alan and Charles both talked about this and the collaboration and importance of that. I do see that some of you had, I think it was 41% that you have, well, there's some challenges with finding the right people and what's most important. And I will say, working on the provider side, it is difficult trying to find the right decision maker at times within the health plan. Who has that authority to get my contract signed and make sure my terms are reasonable? The value-based reimbursement piece, I know the gentleman touched on this as well, especially Alan, but you also want to look at those incentives and penalties. You know, make sure that as a provider organization, you're setting yourself up for success and you're aligned with how the health plans are measured. But one of the challenges is, and you'll see this in the next slide, is that the ACO measures, if you're working for an ACO, are actually slightly different than the managed care organization measures. So when I worked on the ACO, we actually had to map both and train all of our practice staff on both. So that way we were getting credit for accurately capturing that data for both managed care as well as the traditional ACO side. Next slide, please. And at a high level, really from an infrastructure perspective, it's really important that you have quality management, as Alan had suggested, making sure that you're identifying, ways to collaborate together on those measures, moving the needle, making sure you're properly accounting for the risk adjustment and the HCCs. Data management, really integrating data where you can. And again, health plan and ACO data needs vary. So we actually had to map out both sides of the measures and then make sure we were capturing all that data within our practice staff and then being able to pass that over to the health plan as an example. On the health plan side, they look at it with clinical care gap reports. And if you're on the provider side, you probably have many provider portal link, logins to try and manage all those clinical care gaps. Work with your health plans to find out what's the least administrative burden on the way to get that information and have your teams follow up. So that way you can minimize some of the admin side. Practice management, as I mentioned, it's really important. Your frontline staff really should know what are those scheduling, appointment, and accessibility guidelines that I should be adhering to. If I have a member call in from a certain type of plan and I know that the standard is, I have to schedule them within 14 days, make sure that frontline staff knows, not just the doctor or the office staff, or sorry, the office manager. If you're on the provider side, please help encourage and flow down that information so that way there's streamline. Community engagement. So as Charles was mentioning with the social determinants of health, it really ties into community-based resources, community-based providers. If you're with an ACO, you probably have a lot of connections into those in your areas. But it's really important to have those connections, know who provides those services, and make sure that the members can connect into those resources to help their overall health and their overall quality of life. And make sure they have the tools they need to get to appointments or have food on the table. And then last but not least, by any means, this is probably one of the biggest things, is data integration. Just know how you're performing. If the plan's being measured on HEDIS goals, especially if you're a clinically integrated network, you want to make sure that you're understanding your data. Don't just lean on the health plan's data. It's good to look at both as a comparison, but you definitely want to know the quality of your providers that you're bringing to the table, and that helps with some negotiations.
All right, thanks, Jocelyn. Yeah, to your point there on that last rectangle, I guess we'll call it a data integration. We had a slide that said quality, 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 and then I've also heard data, data, data. So
yes,
yeah,
they all tie together.
Yep, absolutely. All right. Well, that concludes our presentation for today. We're going to move on to questions. So if you have not submitted a question, please do so in the question box, not the chat box, on your control box. We did have a few come in. So as I go through these, I'm going to ask the presenter to answer the question based on what slide it came in on. So the first one came in on slide 8, Charles, and it says, how is equity defined and measured? So Charles?
Yes, I believe that your slide 8 is talking about the HEDIS and NCQA focus on equity and what is NCQA doing in terms of to change their focus on equity. Well, I think you see the risk and ethnicity stratification. NCQA has added race and ethnicity stratification to 8 different measures. I think that this continues to just be an ongoing interest for everybody in the healthcare sector. So really trying to meet patients where they're at, looking at those social risk factors and being able to provide some of that that stratification is important. I think it's the focus on diversity and clinical, the focusing on diversity to be more inclusive and really addressing broader social determinants of health and the impacts that they have on patient care is really something that everybody in the industry is starting to double down on.
Yeah, absolutely. Thanks, Charles. Appreciate that. And if you have any questions on that, Charles's information is in the deck, which Garrett will be sending out. Okay, next question is for your section, Alan, on the OIG. It's kind of a two-part question. Will CMS go after the $580 million on overpayments? And if not, and if they're not holding plans accountable, why should plans change behavior?
So I think the answer to that is yes and no. The CMS, I think it was in the 22 or the 23 final rule, said that they would not go after the extrapolated amount for plan years 2017 and prior, but they will go after the extrapolated amount starting with plan year 2018. So
Alan, you're a little hard to hear. Can you repeat that answer, please?
Yeah, sorry. Turn on my volume. Is that any better?
No, but I heard you, so I'll just speak for you real quick. Alan said basically yes and no. The OIG will not go after the 2017 and 2018 extrapolated amounts, but they will going forward. Is it 2025 or 2024 plan year?
Time out. Can you hear me better?
Slightly, yes.
Here, that's better. So what the OIG is, CMS has indicated, I think it was in the 2022 or the 2023 final rule, they said that they would not go after the extrapolated amounts for plan years 2017 and prior, but they will go after the extrapolated amounts starting in 2017 or 2018, I'm sorry. So what that means is, so for plan year 2017 and prior, they're going after, if you substantiated 1 out of 30, they're going to chase you on the 29 member years. For starting in plan year 2018, though, they're going to chase you on essentially the ratio. If you're 1 out of 30, they're going to apply that ratio to the full universe of conditions that they found, and they're going to chase you on that dollar amount. So their intent is to chase the money, but they are giving some relief for plan years 2017 and prior. Only one plan has had an audit published that kind of straddled that time frame. And so for 2017, their liability to CMS is $206,000. For 2017 or 2018, their liability to CMS is $1.1 million from the same audit. So it does have a multiplying effect, that extrapolation. So every indication is they're going to chase the money. Now, plans are pushing back with response letters and all of that. So we'll see where that ultimately goes. I'm sure there's going to be a couple of court battles. But the intent is the OIG considers these errant payments to plans that should be reimbursed, and they're chasing them accordingly.
Okay, thanks, Alan. All right, the next question is also from your section, Alan. If money is recouped by the OIG, will the patient receive refunds of co-payments to providers?
No. Remember, risk adjustment is for revenue to the health plan. It's not tied specifically to claims. It's tied specifically to the conditions that a health plan claim that a member has, and that would be through the total of their medical record. So this isn't a claim by claim recoupment. This is the health plan claimed that a member had lung cancer. They didn't have lung cancer. So we're going to take that part out of that member's risk score, and we want money back. So it's not a claim level type of activity. It's a plan revenue activity.
Okay, great. Thanks, Alan. All right, and Jocelyn, the next question comes from your section. What do you believe is the most important way for provider organizations to achieve successful negotiations with health plans?
So I really think that a lot of what I covered, like just making sure that they understand the value that they bring to the table is going to help with the negotiations. I think it's also making sure that the provider's reading the contractual obligations up front to understand what they're adhering to. Sometimes providers don't always look at the details or track those details that are different between the different payers. But I really think that they need, you need to look at a comprehensive approach. What coverage does your network bring? That can help you with some reimbursement. Also, even looking at the reimbursement, what provider types are included in that reimbursement, and are you getting a reasonable rate? I know we've had some clients that really struggle with getting fair reimbursement from some of the payers, and some of it's just due to the market dynamics and some of the shifts that are happening in a specific market. But we have successfully worked with several providers to help put a framework together of where they really add that value and how they differentiate themselves. It's kind of like the payers have to do that as well. So I really think, focusing on the value add from both sides and looking at what's reasonable and making sure you understand the terms and are tracking them are important.
Okay, thanks, Jocelyn. Another question for you, Jocelyn. What is the secret sauce in keeping provider directories current if the doctors don't report changes to PCOS on a timely basis?
Yeah, so I think the biggest thing is making sure you have dedicated resources to manage your PCOS information. That is so critical. You really need to make sure that somebody's staying on top of that. And if the provider, I'm not sure if this is coming from a provider or a health plan perspective, but most likely it's a provider if they're talking about PCOS. But really having a dedicated resource and a regular schedule to check and maintain that. And then obviously on the health plan side, you're relying on the providers to keep up with that information.
Okay, great. Thanks, Jocelyn. All right, well, that concludes our questions, and hopefully we answered them to your satisfaction. And with that, I'm going to turn it over to Garrett.
All right. Well, thank you all to our speakers and to you, John. This was a really great discussion, and I know there's a lot there, and I'm sure you still, if you have questions, go ahead and submit them now. We're going to get to you through email afterwards, if you'd rather do it that way. But I wanted to encourage you all, as we close out here, to head over to vbcexhibithall.com and check out the ATTAC Consulting Group, the virtual exhibit booth. There's a lot of really cool resources here. You can dive into what they're doing in the value-based care space, learn a little bit more about them. You kind of educate yourself on some of their resources and solutions, and contact them directly, or you feel free to reach out to me as well, and I'm happy to facilitate an introduction for you. And then finally, if you'd like to reach out to our speakers today or to the ATTAC team, feel free to go ahead and do so. Their contact information is here on this slide. And this will be in the slides that you'll be able to download as well. And you'll receive, again, a link to where you can access the recording afterwards. So thank you again all so much for spending your afternoon with us. Hope this was an enjoyable and informative webinar for you. Hope you join us on the next one. Have a wonderful rest of your day and week, and have a happy holidays. Thank you all. Bye-bye.